and hope you are really preparing very well for your EFOG-EBCOG Part 1 exams. I'm sure you already have done a lot of work. So this session of mine would be focusing more on labor and delivery concepts, which people find it difficult. So that's the reason I have chosen this topic. And I would advise you guys to please go through the previous RRR series, which we had done for labor and delivery. I had detailed about all the CTG and how the classification for the EPCOG college goes. Okay, so don't forget to watch that before you start watching for this. Okay, let's kickstart. Guys, remember, every story might not have a happy beginning, but by the end of it, what you become is very important, and what you choose to become, what you think you can become is important. So these exams specifically, even though the number of questions are quite less in EFOG-EBCOG, you will be grilled a lot of concepts. So you need to go back to your basics, because they do not ask a lot of percentage. They do not ask image-based one, but 100% there will be lots and lots of EMQs and SPS based on the concepts. So the hot topics for labor and delivery always has been the intrapartum care and fetal monitoring, the CTGs, the FBS, and all those stuff. Along with that, you need to have the VBAC, which is, as you know, we encounter a lot of women with a cesarean section who come for a trial of labor. Then you have assisted vaginal birth, and then you will have the breech and cart prolapse, and to some extent, I'm going to cover the PPROM and the 2 categories of CS as well in this session today. So just a bit before we go forward, straight away, before jumping into the things. So always remember, whenever you do a single best answer, try to cover the options and then look for the scenarios. What is the scenario? Try analyzing that and come for a conclusion. Always 2 options could be closer. So read the scenario, look for distractors, what is the most important, which is the best treatment, which is the first management, things like that. And it's always a good idea to keep 1 minute per single best answer. And when you come to the EMQs, always EMQs are the ones which test your concept. So lead-in statement, always read that first. We will be sorting out a lot of EMQs because single best answer, everybody is comfortable. And once you read the lead-in statement, like what you're supposed to be doing for the below scenarios, analyze the scenario given and then go for the options. You can definitely do the reverse way. However, you should always think of time management for these questions. And I personally feel whenever you take any exams, it's always a good idea to divide them into rounds. The first round, go for easy ones, which you're very sure of. So remember, in EFOG-EBCOG Part 1 exams, it's always SBS and EMQs mixed. You won't get one paper SBA, one paper EMQ. They are all mixed. So you need to have train your mind like that. Do some SPS, EMQs, SBA, EMQs like that. So you won't be missing on that. Missing on changing how to read the questions. The first round is for obvious and the easy one. Second round, which needs a little bit of a thinking. You remember, but probably you need to think of a bit. And the third thing, something which is purely based on concepts. And the fourth round, which you are not at all sure, you might have to take a guess. And remember, there is no negative marks, so guessing is allowed as long as you think and guess. Okay? Now let's kickstart, guys. So when you read an EMQ like this, okay, obviously when you look into the first glance at the CTG, shows that the baby is not doing well. But how to read this well and how to make sure you don't miss on the important points. So as I said, the first and foremost point which you need to be looking into is your lead-in statement, which talks about most appropriate management options. Okay, so they want us to choose the most appropriate management option for the scenario given. So once you read this, you know that while you are analyzing the scenario, you need to be thinking, I need to think in terms of management, not in diagnosis, not in terms of investigations. Now let's go to the scenario where it talks about, actually, as I'm reading, I'm going to mark you so that you can remember to do that in your exams. Obviously, you can't mark, but as you read, it's a good idea to mark in your brain. So we are dealing with a 36-year-old gravida to para 1 with the previous cesarean section. Again, this is important for me. So because there's a high risk for failure to progress. That means to say, previously cesarean section was done for failure to progress, and she was now admitted with spontaneous onset. Its cervix was 6 centimeters dilated. Presenting part was at 0 station. CTG trace was classified as normal before probably. Oxytocin was commenced at 23 hours, that is around 11 in the night. And her cervix remained 6 centimeters, 2 hours after ARM also. So we are dealing with the previous cesarean section. The first one was done for failure to progress. Now she is still 6 centimeters dilated even after 2 hours. And syntocinon and the amniotomy was done. And syntocinon was also started. Suddenly, CTG has become like this. So midwife examined, unable to identify the presenting part. Vaginal examination, fresh bleeding noted, vertex field gone up than before, seems to be 8 centimeters dilated. Obviously, the clear-cut diagnosis is we are suspecting a scar dehiscence or a scar rupture. And when you look at the CTG, there is a prolonged bradycardia. So obviously, for both maternal and fetal reasons, you need to be going for category 1 CS. So now, do I have this? Because she's like you are suspecting rupture or dehiscence, obviously here you can see category 1. Always look for other options if you have something like that. Thankfully, they don't have, so it is category 1. B will be my answer, and I'm damn sure I'm going to be correct because I have analyzed this question. So this way, if you go, you can never ever go wrong. Hope this was helpful. This is your friend, as I said, lead-in statement. Make sure that you would read that first, okay? Again, the same thing which we are looking into the same CTG. If you could see 1, 2, 3, 4, even without all this, we know that it's a prolonged bradycardia which needs a quicker help. Now, categories of CS. I have seen people literally telling for everything category 1, or they are telling category 2. There is always a confusion. Let me clarify with this one single chart. So category 1 cesarean section where mother or the baby's life is at stake. Okay, you have to do it like a crash CS, like in case of abruption, in case of car prolapse, in case of rupture. All suspicious and pathological comes for category 2, except prolonged bradycardia. Prolonged bradycardia means which is running more than 3 minutes. Rest of suspicious and pathological CTGs come to category 2. I'll tell you why we are very particular about category 1 and 2. Because guys, remember, this is a crash cesarean section, which is going to have a lot of impact for the psychological impact for the mother as well. This should be done so quickly. That's why it will be done under general anesthesia. That is the reason category 1 CS is something which you have to be choosing where there is a dire emergency to the mother or the baby. For the baby, generally, it would be like a prolonged bradycardia or probably a shoulder dystocia, things like that where you know you will be stuck. For category 2, of course, they do say the time within 75 minutes. All other cases in labor, like breach in labor, failure to progress, suspicious, pathological CTG, you would be going for category 2. Category 3, somebody who you had posted for CS, but she comes with the leaking, but no contractions. Then it comes for category 3. And failed induction comes for category 3. Category 4, purely elective cases. Any elective cases, cesarean section on maternal request. CS not in labor, but she's coming for elective one. That is category 4. Hope you guys understood the thing. The most urgent is category 1 and the least urgent elective is category 4. All labor cases comes in category 2 except the one mentioned in category 1. Please remember, it is done under general anesthesia, which should be a salient point, which always you need to be thinking about the psychological aspects what the mother can have. And you know general anesthesia, how unsafe for a pregnant. Okay, let's move to the next one. So here, okay, sorry, I've already given you the answer. So this is regarding, because labor could be regarding so many other scenarios. So here again, let's see us. Let's not look into this. Let's look into what is the question. So the woman described below are HIV positive, various stages. Each woman select the most appropriate next step in their management. Each option can be chosen once, twice, or whatever. So let's read. HIV positive primary gravida presents in labor at 36+6. She has been compliant and combined ART since 14 weeks and her viral load was less than 50 HIV RNA copies per ml at 36 weeks. Guys, we are all aware whenever there is the viral load is less than 50, obviously you can let her go for a normal delivery. So what are the options which we have in normal delivery? Here you can see immediate induction of labor, not required. And labor, I'm just searching. Antibiotics group B, induction of labor, not required. Let's see. Then you have, okay, a low progress of labor and anticipate normal delivery. So out of this, I really feel because she's already going on in labor, A would be the best option, as you can see. Okay, that is what the BIBA guideline says as well. Now, these are easy ones. These are factual ones. I have a next slide which talks about the actually viral load. Don't worry. The next question. Again, need to remember appropriate management. So the HIV positive primary gravida on a combined ERT, okay, and she's since 18 weeks, okay, comes to the hospital for a routine antenatal care. Okay, she's coming to you for a routine antenatal care at 36 weeks. There are no complications with the pregnancy. Ultrasound confirms the baby to be cephalic, all of normal growth. Viral load quantification comes somewhere around 500 copies. So whenever the viral load is more than 400, you need to go for a cesarean section. So she's coming to you to understand how to go about. Definitely cesarean sections would be the best. Again, there are things like consider planned, consider immediate, elective at 38 to 39 weeks, and then you have, I think those are the ones which we have cesarean section. Obviously, the best one would be elective CS at 38 to 39. Okay, because she's coming to you at 36 weeks because of the viral load is more. And obviously, if she comes in labor, then you think of an emergency CS. Okay, and I'm drawing that from this. So please know this mode of delivery for different viral loads based on whether it is less than 50, 50 to 399, more than 399, and term. What would you do? Like less than 50, you have to go for immediate induction. Same thing, but based on the viral load, you would be deciding on that. And whenever there is a premature rupture of membranes less than 34 weeks, you need to discuss with the MDT. You can give steroids, review the viral load, and take a decision more based on that. And somebody coming to you 34 or more, you need to give GBS prophylaxis and elective, probably the steroids, and then based on what their viral load, you would be again deciding on the route or the mode of the delivery. Okay, hope this is clear, guys. Let me move on. Now, again, one more CTG which I've got. Let's go through the options again. Again, my important thing is most appropriate management option for this lady. So I have a 31-year-old primary gravida, presence to labor ward at 37, history of regular contractions. Pregnancy was low, except anomaly scan showed succinturate lobe. Her CTG after amniotomy at 4 centimeters is as follows. I am really worried about the word succinturate lobe, which I will be talking to you in some time. And if you look into that, generally, whenever you have a trace, you can see, actually, if you continue the trace, there is a bradycardia here. Whenever you get a trace like this, it's always good to see the contractions, whether it is a hypersystole which you are dealing with. Since there is nothing like that, then the next thing which you need to think is the baby is not doing well, especially succinturate lobe. Succinturate lobe means you're dealing with probably, especially succinturate lobe, and after amniotomy, they are feeling this. So probably we are dealing with vasa previa, and 100%, the answer would be delivery of the baby by category 1 CS, because you all know the fetal blood volume is 80 to 100 ml per kg. So even if the baby lose 2 to 2.5 ml, that could be really drastic change, and you might end up having a stillbirth. So that's the reason you need to be reading the scenario, analyze, and then choose. Here, I won't go for category 2 because you know that vasa previa, how quickly the baby loses, and it's a good idea to take the baby as quickly as possible. Okay. So I think I've already mentioned this. So this is something which you need to be looking into, thinking of vasa previa. Now, again, one more thing which talks about, again, you need to know about the most appropriate action. Okay. So you have been called to see primary para in labor at 38. Okay, I'm dealing with the primary gravida who is term gestation, fully dilated, okay, with CTG that has a normal baseline of 145, baseline variability of 5 to 10, variable decelerations of more than 60 beats per minute, lasting more than 60 seconds, and present in over 50% of contractions. You examine her, and the head is found to be 2 feet palpable at the level of spines vaginally with no catheter plus molding. Ideally, when you see a scenario like that, you definitely want to go ahead and do something for her. But I agree, there are a couple of things which they haven't mentioned. There is a variable deceleration which is lasting more than 60 seconds. And also they haven't told from how long she's been pushing and things like that. But before, see, lots of other countries have actually not looking into the fetal blood scale sampling. But to understand whether you can wait or with the conservative measures or to proceed for the cesarean section, you need to be going for fetal blood sample. Okay, because fetal blood samples are something which are usually done to select, to know the acid-base balance of the baby, because a drop of blood is collected from the fetal scalp to check the acid-base balance. And this is done in case where you think whether I can wait or I can go ahead with the delivery. Here the problem is 2/5 palpable, you can't do much. Definitely she might end up going for cesarean section, looking at all other things, but how quickly you need to be doing. Do you have some time? To select that, you can go with FBS. Fetal blood sample is still done in European countries. So that's the reason you need to be going for that. One cautionary point for fetal blood sample is, guys, you will not be doing this in case of abruption, cord prolapse, uterine rupture, where you know that you have to take out the baby quickly, because FBS sample takes around 20 minutes or so to get the sample. And by then, either the mother or the baby will be in trouble. So that's the reason you go for fetal blood sample. Otherwise, you could have chosen so many of this, which comes in the way. However, all the forceps, ventus cannot be applied. Cesarean sections, there is no hurry. So that is the reason you need to be going for this. Hope that's clear. Now let's look at some random points. Okay, so with the FBS values, okay, a 30-year, of course, here I'm not giving any option, 30-year-old primey at the PMI of 38. So I know that I'm dealing with somebody who's obese at 39, so term gestation. She has an effective epidural for analgesia. That's fantastic. 4 centimeters dilated at 7 o'clock, 9 centimeters dilated at 11 o'clock, 13 hours, the membrane rupture, draining thick fresh meconium. Okay, so we are dealing with a obese primey who is in active labor, and she is actually ruptured the membranes and there is thick meconium. Vaginal examination revealed fully dilated cervix and vertex was just below the spines in direct accipito posterior. There is no head palpable abdominally. CTG was non-reassuring and the fetal blood sampling showed a pH of 7.23. So whenever you get this, what is the thing which you would be doing? Obviously, the next best thing is to go for trial of instrumental delivery. Please remember, of course, the next slide, we will talk about the FBS values. Apart from that, you are dealing with somebody who has obese occipito posterior. They would need rotation and the chances of them failing is more. That is the reason you need to be shifting her to the theater and do a trial of instrumental delivery, so that you know that if that fails, you can take immediately for a CS. Okay. Now, a 42-year-old primey who has suffered from cardiac disease class 3, there is a slight limitation, conceived with IVF treatment. Presence with spontaneous labor at 39, cervix is 6 centimeters dilated at 6, with ruptured membranes and a clear LICA. At 10 o'clock, the cervix was fully dilated and the vertex was 2 centimeters below the ischial spine. That means +2, somebody with a cardiac disease, but the NYHA classification is class 3. CTG was normal and she has the urge to push. Generally, the tendency is whenever somebody is having a cardiac disease, we feel let's put a forceps or a vacuum. Let's not trouble them. But guys, you need to know the guidelines very well. For class 3, you need not worry about the cardiac compromise they have. So that is the reason you should aim for normal vaginal delivery, allowing her to push as the mother and baby are doing fine. Okay. Now, this is a very important scenario. This is one of the exceptions for instrumental delivery. So you have a 34-year-old third gravida who had 2 normal vaginal deliveries. Previously is, okay, 2 previous normal deliveries. And she is now dichorionic diamniotic twins pregnancy. She presents in spontaneous labor at 37. At 16 hours, she had a spontaneous vertex delivery of first twin. Examination reveals second twin to be in a longitudinal lie with the head 3 foot palpable. Membranes rupture spontaneously 5 minutes later. CTG remained reassuring. At 1640, the CTG became suspicious. And despite adequate contractions with oxytocin infusion, the head remains 1/5 palpable. Vaginal examination vertex was 1 centimeter above spine. So we are talking about a multiparous with a diamniotic dichorionic twin who has been pushing well. Now the vertex is at, actually the vertex is at -1, okay, and she is fully dilated. What would you do? And after 45 minutes, they have tried everything, she is not delivering. Ideally, the cesarean section, if it was a singleton, cesarean section could have been an appropriate option. But there is one exception for the rule of instrumental delivery where you can do a ventouse delivery even though it's at -1. Definitely, this is something the call should be taken by the consultant. And this is one of the options for specifically for diamniotic dichorionic twins who will be able to, who are able to, you are able to deliver them immediately by a ventouse delivery. But again, this is one of the most important rule of an exception, okay? So this is for purely for your knowledge. Now, hope that was easy, guys. Now let's see what these people want us to do. Each patient from above, appropriate action. Okay, let's see the scenario. 30-year-old induced because of preeclampsia, now 7 centimeters dilated. She has an epidural, fantastic. CTG has been showing variable decelerations. Drop in rate over 60 beats per minute, lasting for more than 60 seconds and for more than 50%. That means to say more than 50% of contractions. For example, if she has 4 contractions in 10 minutes, so the variable decelerations is seen in 3 out of 4, okay? And they are lasting for the last 30 minutes. And FBS was performed and level has been reported to be 4.4 and pH 7.22. So what would you be doing? So in this case, the best thing is to do repeat FBS after 30 minutes because we know it's a borderline. Whenever the pH values are borderline, continue the conservative measures, alert your consultant, alert the senior midwife, and repeat FBS after 30 minutes because this is very important. And again, if it remains the same, then you need to inform your consultant and take the call from there. No trainee would be doing the third FBS without talking to the consultant or without the consultant opinion. Finally, what is the pH values which we are looking into are the lactate levels. Remember, pH falls, lactate increases. So pH more than or equal to 7.5. The lactate less than or equal to 4.1 is normal. 7.21 to 7.24. And the simultaneous 4.2 to 4.8 is borderline. Less than or equal to 7.20 or more than or equal to 4.9 is abnormal. So what do we do with them? Normal, continue CTG monitoring, but repeat after 1 hour. Borderline, repeat after 30 minutes. Abnormal, expedite the delivery, don't wait. Whether it is a cesarean section or instrumental delivery, depending upon the scenario given. So this is what it talks about. Okay, so the same thing which we talk about, obviously, when there is CTG abnormalities only, you will be doing the fetal blood scalp sampling. And there is something called fetal scalp stimulation. See, fetal scalp stimulation is compared to FBS, it's a non-invasive one, where you stimulate the fetal scalp to see if there is any amount of acceleration noted. And obviously, in all other countries like the UK, they have stopped the FBS, but in European Union, they are still doing. That's why you need to know these values. Now, let's move a bit from labor and delivery. Single most likely diagnosis from the above list of options. A 26-year-old woman underwent CS in her first pregnancy for fetal distress. This current pregnancy was uneventful and she went to spontaneous labor. She requested an epidural analgesia at 7 centimeters. Shortly following the insertion of the epidural, fetal heart rate pattern became pathological. So what are you looking into? So what is the thing which could have caused, whether it is something to do with this anesthesia problems or you are dealing with the pregnancy thing? definitely please remember, whenever you have a lady whom you are giving a trial of scar, see, this could be a coincidental one where they have actually given the spinal or the epidural, and CTG became pathological. In spinal or epidural, CTG never becomes pathological. There could be changes like a pseudo-sinusoidal pattern. Generally, in sinusoidal pattern, it goes like this, okay, which is seen in fetal anemia. But if it is after epidural, you are seeing pseudo-sinusoidal, that it will be like this. That is, beat to beat variability is maintained. However, it is a sinusoidal pattern is still seen. So this is the one which you will be getting in case of epidural. So it won't be pathological, specifically when you have something previous years. You should always be thinking of scar rupture or the uterine rupture as first option. So I hope this is clear. The next one. Unbooked woman was admitted via ambulance unconscious. Only history available is that she was feeling unwell for previous few days with headaches and had collapsed at home shaking. An examination unconscious, abdominal mass consistent with the 24 weeks of pregnancy, blood pressure was 180, 110, and urine analysis revealed proteinuria. It's a very simple and a straightforward. Obviously, eclampsia is the correct answer. And guys, there could be things like, for example, if you might think of differential diagnosis like epilepsy, but here are any other pregnant women, the first thing which you need to rule out is eclampsia before you think of epilepsy or anything else. So rule out the first common causes. Okay, guys? The progress of labor. This slide I particularly included because there are a lot of people who always ask me about this. So whenever, irrespective of the parity, you must remember, in case of suspected delay, multiparous or a primiparous, it would be the dilatation would be less than 2 centimeters in 4 hours. If that is the case, the next thing what you do is you do an amniotomy to release the natural prostaglandins and to get the contractions. Obviously, because it is natural, you need to examine the patient after 2 hours. And after the examination, if multiparous or a primiparous, if there are no much of a changes, that is less than 1 centimeters in 2 hours, you need to be starting oxytocin. Okay, so you have examined 2 hours, but if you see less than 1 centimeters in 2 hours, then you start the oxytocin. Be very careful for multiparous because you need to think of a cephalopelvic disproportion. Once you're given oxytocin, you need to be rechecking them after 4 hours because this is a natural prostaglandin, but this is titrated, given from exterior. So that's the reason you need to be reassessing after 4 hours. And if the dilatation is more than 2 centimeters, then nothing to worry. You continue monitoring and see how it goes. Repeat after 4 hours. If it is less than 2 centimeters, you need to think of inform a consultant and expediting the delivery either by cesarean section or by operative delivery based on the findings given to you. Okay, so obviously most probably it could be for a cesarean section because we are talking about a delay in a first stage of labor. Hope this is clear. Now let's talk about the duration of labor for primi and multi in case of second stage. So once they start pushing, actually this has been very clear in the current guidelines. So just remember this, a primi without any epidural, she has to deliver within 2 hours. A multi without epidural, she has to deliver in 1 hour. However, if there is epidural, you have to give additional of 1 hour. So if somebody is on epidural, 3 hours for a nulliparous and 2 hours for a multiparous is something which all of us need to be giving. Okay. Now there are a couple of facts which all of us must remember. The type of instrumental delivery. Guys, even the thing which I showed you, the duration of the labor and also the CTG changes. Please remember, whenever a labor scenario is given to you, you will always put across the patient in front of your eyes and think. Not that if 3 hours is over, somebody's CTG is good, she's doing very well, you won't jump and actually deliver her. before that, you will make sure that this is like if somebody is going to deliver in another 10-15 minutes, you need to give them that space. What I mean is these things give us when to cut short the labor. Now, there are different types of instrumental deliveries: outlet, low, and mid cavity. So you all know the station, so I'm not talking about it. The only one concept which I need to inform is, I need to tell you is, always there is a false thing that all the rotational deliveries should happen in theater. No. If somebody is actually on a good analgesia, they could still, for example, somebody is on an epidural analgesia, they need a bit of a rotation. They can deliver especially in multiparas, they can deliver in a labor room, which I would be telling you. Okay, so remember, multiparas, occipito anterior, even the mid cavity, she can deliver in the labor room. That is one point which I wanted to make sure. Now let's look at a couple of scenarios. A primary gravida, 37 weeks, low risk, advancing well, head on perineum, no concerns otherwise, 2 hours over on Entonox. Okay, so what would you want to do? Okay, for this particular lady, obviously she's doing well, don't do anything, allow her to push. Now, when you go to the multigravida at 39 weeks on epidural, occipito anterior on epidural, now 2 hours over station at spines. Okay, so the station at spines, because we are talking about the mid cavity. So here, because she's a multiparas, occipito anterior, no need of rotation. So please make sure that she can deliver in labor room. This is what I was trying to tell, because she doesn't need any rotations. Like unlike occipito posterior, we are dealing with somebody who is already having a good analgesia and a multiparas who can easily deliver. So instrumental delivery in the labor room is an appropriate one. Now let's look at this, who has a no pain relief, multiparas lady, no pain relief, head is at spine, occipito anterior and are over. So we know that the time is over, the head is at 0 and she has no pain relief. Obviously, she should be delivering now, but do you think she would be able to do without any assistance? Not possible. So that is the reason you need to be, actually here also, you could have delivered her if she was on epidural, but the pudendal block, the only option which you will have is pudendal block. In this case, if you give a pudendal block, when you take the baby from the spines lower, that could cause a lot of pain. So that is the reason you need to shift her to the theater, give a short spinal epidural and do the forceps delivery. The next one is multiparas, fully dilated and pushing for 2 hours. She is examined and found to be fully dilated. Left occipito anterior position, vertex 1 centimeters below the ischial spine with 1+ caput and no molding. So what do we do here? Since everything is there, she is having a 1+ only and left occipito anterior. So you can easily do the instrumental delivery in the room. For her, no need to shift her to the theater. Hope I'm making the concepts clear. The next one, multiparas 39 weeks on epidural, occipito anterior, now 2 hours over station at spines. Obviously, you can deliver it in the labor room because no rotations or no difficulties are seen. The next one, the last scenario on this is somebody who is an occipito posterior at 0 station on epidural analgesia and an obese lady where we know the failure rate is more, 100%, you have to do a trial of instrumental delivery in theater. So guys, the simple concept is multiparas with occipito anterior with at spines. If not on good analgesia, you need to shift it to the theater. But multiparas, occipito posterior, if she's at 0 to +1 with a good analgesia, no other comorbidities, you can deliver in the labor room. So please remember, all mid cavities need not be done in the theater. Only difficult rotational instrumental deliveries you will think in terms of theater. Otherwise, rest. You should look at a couple of things: gestational age, parity, the station, rotation required or not, what instrument you are going to use, and analgesia sheets on. So, a few things about the shoulder dystocia. Guys, here you can see a lady who has been a low-risk multiparas. 3rd pregnancy, estimated fetal weight is not much. And the midwife has noted difficulty with delivery of the face and chin. Head started retracting, right? Whenever there is a head started retracting, the turtle sign, it is shoulder dystocia. She has tried macro upwards and suprapubic with no benefit. What is the best maneuver angel should try in this situation? Because the midwife is all alone the best thing which she can do, because macrobots is done, suprapubic is done. The next best would be the all fours position, because the midwife is alone. And that's the reason you go for all fours. And the second one, you can see again, the low risk multiparous lady, she has been referred by midwife to hospital. That means to say the midwife is the patient is in hospital. She's progressed well, again, called for help. She has noticed shoulder dystocia, called for help. First maneuver. Always the first maneuver is macrobots. So the difference is there the midwife is alone. Macrobots are probably done, nothing happening. Instead of the internal rotation maneuvers, because of the competencies, you can go for all fours. Here the patient has reached hospital and there is a turtle sign. The best thing to go for, the first best thing which she can go for is a macrobots. Okay. I think I had played this animation before also. So macrobots is actually flexing and abducting the legs, okay? In that hyperflexing and hyperabducting, because this could help in rotation of the maternal pelvis. And this we know, this would be a suprapubic pressure which we would be giving, okay? Both of them account for a very good success rate of 90%. Even all fours has a good success rate of 83%. Guys, know the obstetric emergencies very, very well. Now, I think this is again another EMQ, appropriate management options. What we are looking into here, a 38-year-old primary conceived twins after the fourth attempt at IVF was induced at 38. She delivered first twin 45 minutes ago. The membranes of the second twin are intact. Twin is lying longitudinally and presenting cephalic. Syntocinon was started 30 minutes ago and uterine contractions resumed shortly after. A sudden unrecovering bradycardia has developed with some brisk vaginal loss. Okay, so if you could see here, there is Cesarean section which is there. Definitely that could be the best one. But some of the people, they do say that you could actually go ahead with the, actually this, I think there is something wrong with the question, because this should be breech, guys. It cannot be longitudinal. This should be breech, because if it was longitudinally cephalic, then the option is Cesarean section. If it is breech, then the best thing would be to go for assisted breech delivery if she is fully dilated. And if it was transverse lie, the best thing would be internal podalic version. So I shall correct immediately. So the thing here could be, it should be presenting as transverse lie. So because the transverse lie is the one which can have, where you can do a internal podalic version with an assisted breech extraction, would only be spoken for the transverse slide, where you go for, you have to convert the transverse slide to breech and take it out. Obviously, for cephalic presentation, if it was like a previous question, you go for a category 1 CS, because unless you can put a, probably you can put a forceps or a vacuum or something, because the question, there was an error, so I've changed it now. So the thing is, the baby is transverse slide, so the next best thing is do an internal podalic version and assisted breech extraction. And a couple of these questions on when to remove or when to give the low molecular weight apparent. Okay, somebody is scheduled for induction of labor who had a DVT. Obviously, you know that they have to be stopping 24 hours before. The second scenario talks about CS was performed under spinal anesthesia. She was placed on a, before in the antenatal period, she was placed on a therapeutic dose. So when to give the next one or when to remove the epidural catheter. Ideally, recommends the low molecular weight heparin after 4 hours after removal of epidural catheter. And the last one is this, again, this lady was started on therapeutic dose and booked an elective CS section at 38 weeks. Obviously, the before anesthesia, 24 hours before it should be stopped. So all these things are put here: prophylactic 12 hours before, therapeutic 24 hours before. After spinal or epidural catheter, you have to start after 4 hours. Prophylactic unfractionated heparin, you can stop 4 hours before. Therapeutic, if it is IV, 6 hours before. Subcutaneous, 12 hours before. The whole point of why we are talking about this is to prevent the epidural hematoma for all this. And a word about reduced fetal movements. So whenever somebody presents with the reduced fetal movements, the first thing is auscultate with the handheld Doppler. Obviously, if at all, if the presence of fetal heartbeat is not confirmed, quick quickly you should do an ultrasound. If fetal viability is there, you have to do a CTG. But the first thing is auscultate the fetal heart sound. And I think the couple of things which I would want to talk is again the PPROM. Again, guys, very, very important. Sterile speculum examination is something which all of us need to remember. If there is a PPROM, you can actually detect by doing IGF BP1, RPAMG1, or amniosure, whatever you call. And remember, management would be erythromycin. Unless she goes into labor, there is no hurry to deliver her immediately. Steroids, if at all, if she's going to deliver, you need to think in those terms. And definitely magnesium sulfate should be offered less than 30 weeks. And the birth, most important timing of the birth would be you can wait up to 37+0 before you think of ending this pregnancy. Okay, and a couple of important factors about the breech and the ECV. So the breech, the ECV is something which is generally very successful when it is done in antenatal period. It is generally, you can say, half of them would be successful, irrespective of the parity. 6 out of 10 in multi, 4 out of 10 in primary. And remember, these people should be delivering in the hospital. And obviously, there's always a possibility of reversion and anti-D to be given to non-sensitized RH negative women. Okay. And yes. And also few things about the card prolapse. Please remember card prolapse. You should consider category 1 CS card prolapse with abnormal CTG. Otherwise, they do mention you can do category 2 CS even with the normal CTG. So that is something which you need to remember. And all of you know that head down position and probably elevating the bladder, all those things are important. And don't forget to inform the neonatologist. And definitely the late IUFT, you need to know the doses of the MIFI and the meso as mentioned here. So guys, coming to one more EMQ which I wanted to do here. So if you could see this EMQ, again the CTG is there. Again, you need to come for an appropriate management. So you are dealing with a CTG who was laboring and spontaneously at full term in her second pregnancy. First baby had been born by CS. Okay, again, failed post-induction of labor. At time, this was recorded and she was 4 centimeters dilated. Looking at this, you know that the CTG is definitely not normal. Lots of variable decelerations. You know, there is a W pattern here you can see, and there is a overshooting which you can see. So 100% you will be going for a cesarean section. Note the point, not category 1, it is category 2. So guys, I have given you, because this is a very short lecture or a short presentation, I wanted to make sure that you guys understand the importance of reading and analyzing the scenarios. As I said in the beginning, please go through the RRR series of the previous one, where I've done a detailed one on the CTG, what to be done, how to interpret, this specifically because they do follow still the FIGO guidelines. So I have given that there. Please go through that. Here, what I've done is summary of important topics which I have given. So please make sure to go through. And as I said, a couple of questions could be reframed in a very different way. Read the questions carefully and answer. I'm sure you will all be able to do this very well. All the best, and you would be fantastic. And definitely, my humble suggestion for all of you is to read the EMQ very, very, very carefully, analyze, choose the option in your head, and then only search for the options. All the best, guys. May success be yours. Thank you so much for watching. All the best.